It's my privilege to introduce our morning keynote, Dr. Shaili Jain. Dr. Jain is an internationally recognized psychiatrist and PTSD specialist who currently serves as the medical director for the integrated care at the VA Palo Alto healthcare system. She is a trauma scientist with the National Center for the Post-Traumatic Stress Disorder, a consortium which is widely regarded as the world's leading center of excellence on PTSD. She is also a clinical associate professor affiliated with the Department of Psychiatry and Behavioral Sciences at Stanford. Dr. Jain's work is widely accredited for sharing the role that paraprofessionals and peers can play in the treatment of American veterans with PTSD. Her research has been published in many of the world's preeminent journals. Her essays and her commentary are a part of modern culture and media, including public radio and elsewhere. Her debut book is entitled The Unspeakable Mind: Stories of Trauma and Healing from the Frontiers of PTSD Science. This book stands as a definitive guide and offers lasting hope to sufferers, their loved ones, and healthcare providers everywhere, including all of us. So please join me in welcoming Dr. Jain.
Good morning. Thanks so much for that introduction. What was missing from my bio is that I spent 10 years as a practicing physician right here in Milwaukee. Yes? When coming to Milwaukee is always like coming home for me, and when I was reflecting on that yesterday, it feels like a full circle moment to be here talking with you all today. The 10 years that I spent working as a physician in Milwaukee were probably the most formative of my career, if not my life to date. So I have a lot of gratitude to be invited here to speak with you all today and to talk to you about PTSD. So I'm a psychiatrist and a post-traumatic stress disorder specialist. I'm also a researcher committed to advancing the science of PTSD. My compulsion to do this work is rooted in my own family history of trauma and tragedy suffered in the 1947 partition of British India. The partition was this really brutal chapter in the history of the South Asian subcontinent. 2 million perished, 75,000 women were raped and mutilated, and 14 million were forced to flee. It was the largest refugee crisis of the 20th century. Now, my paternal grandfather was murdered in partition-linked violence. And as a result of his death, my dad, who was age 10 at the time, was orphaned. He was forced to flee and live as a child laborer in the newly independent India. Now, 20 years later, my dad would move to England, and that was where I was born and raised. But despite this separation in time and geography from what had happened in 1947 and in India, I felt I spent big chunks of my youth living in the shadow that partition had cast on my dad's life. And with this feeling that no matter how much I loved him and he loved me, there was a part of him that was going to remain inaccessible because of what had happened in 1947. And I think unraveling the mysteries behind that inaccessibility has been a really driving force in my own career. So I want to invite you all to engage in a really uncomfortable exercise. Imagine if tomorrow you survived the unspeakable. Imagine if you were raped, or you survived a brutal assault, or you were robbed at gunpoint. Maybe you escaped a deadly house fire or a natural disaster, or even an act of war. Now, I imagine some of you are thinking, I don't need to imagine. I've lived through such things. I'm a trauma survivor. And I wouldn't be surprised if that was the case. More than half of Americans say that they've lived through a major trauma in their lifetime. And there's a subset of Americans who have lived through multiple traumas in their lifetime. Now, once the danger is ebbed, it is natural for you to feel distress. It's natural for you to be troubled by reminders of the event. It's natural to have nightmares. You might feel like this for hours. You might feel like this for days. You might feel like this for weeks. Thank you. The good news is humans by design are psychologically resilient. The vast majority of you will heal naturally with the passage of time. The bad news is a substantial minority of you won't heal naturally. You won't be able to organically transcend the trauma. Instead, you'll suffer every day with invisible wounds. You'll develop post-traumatic stress disorder, and you wouldn't be alone. At any given moment in time, there are 6 million Americans suffering with active symptoms of PTSD, and there are many, many millions more suffering with something we call partial PTSD that doesn't quite meet the textbook criteria, but nonetheless, these people suffer and they need help too. So the statistics really speak for themselves. If you're lucky enough not to experience a trauma in your lifetime, the odds are someone you love, someone with whom your life is inextricably intertwined in the community where you work, in the community where you live, where your children go to play, where they go to school, someone will have their life destroyed by PTSD. So none of us can afford to ignore it. So what is PTSD? How does it impact a life? How does it impact a family? What about a community? In my book, The Unspeakable Mind, I deconstruct post-traumatic stress on every level, from the biological to the cellular, from the psychological to the emotional, from the cultural to the global. In essence, PTSD is a psychological condition that has been documented since ancient times, but it remains really elusive. It just dips in and out of our national consciousness. PTSD is famous for causing nightmares, an exaggerated startle reaction. It's famous for causing flashbacks. Lesser known but equally devastating is how it renders an emotional life barren. It mutes happiness and leaves the sufferer living in this raging irritability and on the perpetual verge of alienation from the world and everybody who loves them. PTSD's incapacity isn't brought on by poor lifestyle choices or moral weakness or character flaws. Rather, it's a really complicated interplay between our brain, our bodies, our genes, and our environment. And I want to explore all of these 4 dimensions in a little bit of detail. So what does the brain of someone with PTSD look like? In the PTSD brain, we have a temporal lobe in our brain. And in the temporal lobe of our brains, there's an area known as the hippocampus. The hippocampus is the part of our brain where we process short-term memories. That is smaller in people who have PTSD. Also in the temporal lobe is this region known as the amygdala. That's where we process emotions like fear and anger. That is amped up in people who have PTSD. The frontal lobe of our brains is where we execute judgment. It's how we make decisions. It's how we go about planning our day. That is underactive in people who have PTSD. In addition to these neurobiological changes, people with PTSD have altered levels of the stress hormone cortisol, noradrenaline, and serotonin. And it's a combination of all these neurobiological and neurochemical changes that lead to the symptoms that we associate with PTSD. Memories. Disordered memories are so integral to the pathology of PTSD that it's come to be known as a disorder of memory. Nightmares and flashbacks, those quintessential symptoms of PTSD. The classic PTSD nightmare is a repetitive replay of the trauma. They can happen several times a week for up to decades after the person experienced that original trauma. The flashbacks, they're this involuntary reliving of the trauma and can be triggered by a variety of trauma cues, many of which are present in our everyday environment. These flashbacks literally yank the survivor out of the present, leaving them beholden to their past. Lesser known are the symptoms of avoidance and denial, which are also integral to the pathology of PTSD. People literally do not want to face the elephant in the room. The last person they want to see is someone like me, who's a mental health professional. Instead, what they do is they lead their life in this very narrow, constricted way. They avoid any reminders of the trauma, whether they're psychological reminders, emotional reminders. They avoid people and places that remind them of the trauma. But they end up leading this really constricted life. It's a half-lived life. The most disruptive dimension of PTSD symptoms, the outbursts, the recklessness, the hypervigilance, the exaggerated startle response. And then there's the mood states of PTSD, anger, shame, guilt. All these symptoms collectively disrupt the life of a PTSD sufferer and inhibit their ability to love, to create, and to work. We now know that there is a subtype of PTSD which has its own unique footprint. It's called the dissociative subtype of PTSD. In the face of trauma, some people fight, some people flee, and others freeze. 15 to 30% of PTSD sufferers have this dissociative subtype, where they freeze, they check out, they dissolve, they dissociate when they're faced with a trauma. One thing I wanted to point out is that children who've experienced severe and prolonged childhood abuse are much more vulnerable to developing this dissociative type of PTSD when they grow up as adults. When they're children and they're dependent on primary caregivers for their physical survival, when they're dependent on primary caregivers for their housing, their food, their clothes, dissociation is a way for them to survive when that same primary caregiver is the perpetrator of abuse. So when they're kids, that's the only way they can literally physically survive. The problem is when they grow up into adults, their past haunts them. This form of PTSD, this dissociative subtype, has a much poorer prognosis. PTSD does not live alone. It goes hand in hand with a variety of other psychiatric conditions, from depression to anxiety to addiction, and all sufferers have an elevated risk of death by suicide. We can't talk about PTSD without talking about addiction. The two go hand in hand. There's something about the allure of self-medication that is too powerful for PTSD sufferers to ignore. Seeking an altered state is just something that PTSD sufferers are drawn to. And the addiction could be anything. It could be pain pills, it could be alcohol, street drugs, food, sex, nicotine, gambling, you name it, it could be anything. The problem, as I'm sure you all know, is oftentimes the addiction morphs into a huge problem of its own and derails the life of the sufferer completely. So what about the bodies of people who live with PTSD? How does PTSD take a toll on physical bodies? PTSD seeps beyond the confines of mind and body. It seeps into cells, bodily organs, bodily systems. It's emerged as a major risk factor for conditions like obesity, cancer, and heart disease. And what about the role of genetics? When we think of PTSD, we like to think of this external trauma. The reality is PTSD is a highly heritable condition. Up to a third of what determines who develops PTSD after exposure to trauma is actually determined by our genes, literally how our brains are wired and how our body mounts a response to stress. On top of that, the neuroscientist Rachel Yehuda from Mount Sinai School of Medicine has recently unearthed evidence to suggest that there are epigenetic mechanisms at play in PTSD. And what do I mean by epigenetics? How living with PTSD literally determines which of your genes are switched on and which of your genes are switched off. And then those altered gene expressions are passed down to future children via a man's sperm or via a woman's eggs. So subsequent children literally inherit this altered gene profile, even though these kids themselves may never have been exposed to a traumatic event. They're literally carrying these sorrows in their blood. So when we think of mass traumatization, when we think of Holocaust, when we think of slavery, genocide, torture, atrocities that impact millions of people at any one period of time, you start to get a sense of the deep footprint that PTSD leaves, a footprint that can literally span generations. And what about the role of environment in PTSD? Regardless of the type of trauma, research has unequivocally shown that social support is vital to healing from PTSD. In this way, PTSD goes far beyond the biology of an individual and really extends to our society. So a positive social support network heals symptoms of PTSD. And conversely, a negative social support network, it's like rubbing salt into wounds. It damages. On top of that, research has shown that survivor perception is crucial. Does the survivor feel like they were supported? Does the survivor believe that they received support? And this research sends us all a really invaluable lesson. Attempts to support trauma survivors, no matter how well-intentioned, have little impact if we don't meet survivors where they're at, psychologically and emotionally, and if we don't tailor these attempts to the specific needs of those that we're trying to help. When it comes to PTSD, geography is destiny. What if you can't tap into a robust social network? What if your friends, your family, your coworkers, your neighbors can't offer you the support you need? Maybe they're struggling themselves. What if, for some reason, the powers that be don't recognize or acknowledge your suffering? Or maybe they don't feel you deserve support. It turns out your zip code is a huge factor in the quality of social network you can tap into. And the best lessons we have learned has come from the research that was done after Hurricane Katrina. It turns out the pre-disaster condition of disaster-hit communities matters a great deal when it comes to PTSD. The reality of pre-Katrina poverty and social adversity meant that families were already struggling before the hurricane hit. On top of that, poverty and social adversity determined who bore the brunt of that devastation. African American residents of New Orleans made up to 85% of those who lived below the poverty line, and they were more likely to live in the flood-prone regions of the city that were worse hit by the hurricane. Researchers followed a lot of survivors of Hurricane Katrina, and they found that PTSD rates were found at rates higher than what they would have predicted. And who bore the brunt of the PTSD? Children and the elderly. The stark reality of poverty and its role that it plays in PTSD can't be ignored. And what about race? We do have data for some minority groups. We have a lot of good data from African American communities that have been studied in the aftermath of exposure to trauma. Violent traumas are perpetuated more frequently against African Americans. Higher rates of PTSD have been found in African American combat veterans, African American low-income women, and African American youth who live in high-crime inner-city areas. But there is a little bit of a wrinkle in this data. PTSD in African Americans is more accurately explained by zip code than race. Living in an impoverished urban community is the strongest predictor of if you're going to experience a violent trauma. It trumps skin color. So for African Americans with PTSD, when you factor in access to education and removal of poverty, the contribution of skin color shrinks. You're more likely to have PTSD if you are poor, have a lower educational level, are unemployed, or are homeless. And unfortunately, in America, one is more likely to find oneself in those categories if one happens to be African American. So this data on race and PTSD really underscores why tackling structural racism, poverty, implicit bias is crucial to fighting PTSD. And it also underscores the vital importance of lifting the wellness of whole communities. It's not enough to focus on individuals. So PTSD is an inescapable part of all of our lives and the world we live in. Of course, treatment is vital. And I do want to touch a little bit on treatment, because in the last 20 years, with 9/11, with the wars in Iraq and Afghanistan, with the Great Tsunami, Hurricane Katrina, there has been a huge surge in the science of PTSD. And what has emerged from all that investigation is a plethora of treatments that are really well studied and really effective. The take-home point about PTSD today is that what was once considered disabling and incurable is today really manageable, really treatable. So we have to have a lot of hope. I'm sure many of you are familiar with the talking cures that we know work for PTSD. There's specific trauma-focused psychotherapy like prolonged exposure, cognitive processing therapy, EMDR, all really well-tried and tested treatments that are effective to help PTSD sufferers heal. There's a lot of non-trauma-focused psychotherapies too, which focus more on the day-to-day living and what people with PTSD deal with, things like STARE, acceptance and commitment therapy. And then even beyond talk therapies, tapping into dimensions that go beyond the cognitive, mind-body treatments, things like yoga, hypnosis, mindfulness, they've emerged as really powerful and popular adjuncts for people who live with PTSD, who really want to focus on how PTSD impacts them physically, how they're carrying trauma in their bodies. Now, I want to be clear, talk therapies are the first-line treatment for PTSD. The evidence that we have to support their effectiveness is unparalleled. If I loved someone with PTSD, I would want them to receive one of these talk therapies as soon as possible. But sometimes talk therapy doesn't work, or sometimes it's not an option for many reasons, and then that's when we think of medications. And we do have good data to support that medications like antidepressants can be really helpful for people with PTSD, even if it's just to reduce that physiological arousal and the kind of serotonergic impact of living with PTSD. You know, a month doesn't go by in my clinic when I don't see someone have a life-altering transformation with medicine. So that is an option too. We now know that some medications are contraindicated. And as we speak, there's a lot of innovation going on, new medications being tried and tested for PTSD all the time. So the future is bright. Beyond treatment, though, what I really want to highlight to you all today is the role of prevention in treating PTSD. What if we could prevent PTSD? And if so, how? Primary prevention is the purest form of prevention. Imagine if you could prevent family violence. Imagine if you could prevent gun violence or sexual violence. Then the PTSD related to such traumas just simply ceases to exist. I know it sounds idealistic, but I want to share with you some really exciting work being done with Stanford University researchers who have collaborated with the nonprofit No Means No and the Kenyan government. And what these researchers have done is they went to Kenya and they trained 2,000 Kenyan high school girls in a 6-week self-defense program. And at the heart of that self-defense program was this desire to quash the cultural notion that a girl should stay quiet or obedient when confronted with a harasser or a sexual attacker. The location of this Kenyan study is really important, because more than half of Kenyan women report having been sexually assaulted when they were children. So the researchers trained up these high school girls with this program, and then they followed them over time. And 1,000 of these girls went on to use what they had learned in the training to fend off a subsequent harasser or attacker. Now, self-defense programs in themselves are not new, right? What's exciting about this research is that the Stanford researchers are using sophisticated statistical methodologies to really pinpoint what the secret sauce ingredient is in that training program. And what's really exciting about unraveling what the secret sauce ingredient is, when we know what they are, then we can scale and effectively replicate such programs for communities all around the world. So that's really exciting news for us. Now, primary prevention isn't always possible, as much as we would like to prevent all traumas. So researchers have ventured into this area known as secondary prevention. In the case of post-traumatic stress disorder, it's a period known as the golden hours, a period of time between exposure to trauma and the onset of PTSD, an opportunity for medical intervention to set the brain on a pathway to recovery. Researchers at Oxford University hypothesized that if they could engage a trauma survivor in a visually absorbing task right after they were exposed to trauma, they could disrupt memory consolidation. Now, memory consolidation, we all need that. Whenever we have a memory, when you have a memory of coming to this conference today, your brain has to put that memory through a process of consolidation. You have to allow that memory to ripe so that tomorrow you can remember that you came to this conference. The problem with PTSD is that process of consolidation goes into overdrive. And that's why the memories of PTSD are so intrusive and so visual, and they stay with you for decades. So the researchers at Oxford theorized that if they could distract the survivor with a visually absorbing task and disrupt that memory over consolidation, that they could prevent PTSD. So what did they do? They went to the emergency room, they found 70 people who'd survived a major car accident, and they divided them into two groups. The first group was asked just to keep a log of what they had gone through since surviving the car accident. And the second group was asked to engage in a visually absorbing task. And they were asked to play the computer game Tetris for 20 minutes. Lo and behold, the Tetris playing group, when they were followed up in the weeks after the car accident, were significantly less likely to report symptoms of PTSD. So this notion of disrupting memory consolidation in the immediate aftermath of trauma and literally thwarting PTSD seems to have some legs. And it's a really, really promising approach. There's a lot of other innovation and research going on into how to prevent PTSD via these primary and secondary pathways. There are wonderful interventions to prevent domestic violence in high-risk couples. There are programs that have been tried and tested to prevent family violence for at-risk families. Other golden hour interventions that involve administering medications to people who've survived a trauma right there in the emergency room after they've survived that rape or that brutal assault. All of them are gathering steam. There's a lot of encouraging development on that front. But right now, the most practical form of prevention that takes place on a day-to-day basis when we think of PTSD is tertiary prevention, otherwise known as early intervention. You know, when we think of breast cancer and heart disease today, we know screening, early detection, early treatment makes all the difference. It literally saves lives. The same is true for PTSD. But unfortunately, only 1/3 of PTSD sufferers ever get the treatment that they need, because there's a lot of barriers. First of all, PTSD is tough to diagnose. A lot of medical professionals either don't know how to diagnose it or they misdiagnose it. Secondly, PTSD is a challenge to treat. Like I said, the very nature of the condition makes the sufferer avoidant. It makes them mistrustful. The last thing they want to talk about or address is the trauma. So you've got an instant barrier to them engaging in treatment. Thirdly, PTSD sufferers are hard to reach. While it's true that any one of us could develop PTSD, the reality is the socially disadvantaged bear the biggest brunt of PTSD, and oftentimes they just don't have access to high-quality mental health care. And then the final barrier is that stubborn barrier of societal stigma. It's hard to believe, but we still live in an era where it's hard for people to admit mental health distress and then to get the treatment they need to get better from it. So I've spent the last 10 years trying to address these barriers and trying to put a dent in these barriers. Because the problem is when PTSD sufferers don't get help in a timely fashion, remission rates plummet, and people just suffer needlessly for years and years and years. I want to share some of the ways that me and my team have come up with to try and break down these barriers. Many of them sound pretty simple, but they're remarkably effective. The first thing I did was 10 years ago, I ditched my regular psychiatrist office. So, I used to have an office in the mental health clinic. It had nice furniture, nice rug, nice wall furnishings. You can imagine it had good lighting. And I ditched it, and I moved my office here. A regular exam room in a regular medical clinic. And why did I do that? Very few PTSD sufferers will ever make it to my clinic. But a lot of them show up in primary care for many reasons. So by me literally shifting my location, it increases access to mental health treatment for people who need it. So what we did is in primary care, we instituted a lot of screening tools for common mental health conditions, of which PTSD is one. And everybody who comes in to see their primary care doc will be screened at least once a year. And anyone who screens positive will be referred to a mental health professional right there in their primary care doctor's office. And it could be they screened, it was a false positive, or it could be that it was a true positive. And if it was the latter, they'll be offered an evaluation, they'll be offered treatment, and the treatment can even take place right there in their regular doctor's office. I found that the stigma about seeking mental health care simply dissolves when we use these primary care mental health integration models. Why? Because I think we as a medical profession send a really clear message to survivors that there is no health without mental health. I feel like I'm seeing the patients I've seen my entire career. I'm just meeting them 20 years earlier, before their symptoms were entrenched, when their symptoms are just easier to treat, much more amenable to treatment. And this isn't just my experience, the research backs it up too. PTSD sufferers who receive care in these integrated care models, they just simply do better, their prognosis is better. And it's not just primary care mental health integration. Beyond primary care, PTSD interventions are being integrated into emergency rooms, ICUs, NICUs. We researchers and clinicians, we're getting it, that it's really vital that we meet survivors where they're at, not just psychologically and emotionally, but literally, physically where they're at, where they're to be found. Even educators in schools are being trained to be more trauma-informed. That is, that they should have this enhanced awareness of how traumatized children learn and behave and play, so that the process of education doesn't re-traumatize the child. And there are so many other ways that we are trying to engage in tertiary prevention of PTSD. So many other ways that we're trying to reach the hard to reach, that we're trying to make PTSD care accessible, available, and acceptable for all. Technology is one way. There is a smartphone application or an app called PTSD Coach. It's free. Anyone who has a smartphone, which, by the way, 2/3 of Americans have, can download this app. It was developed by some really smart and thoughtful psychologist colleagues of mine at the National Center for PTSD, and it was designed as a self-help tool. It's got great psychoeducation about PTSD. It's got tips and strategies for sufferers to use to help them with their day-to-day symptoms. It's a wonderful starting point for someone who's ambivalent about seeking formal mental health attention. So that's the power of technology. What about peer support? At the hospital where I work, we've hired peer support specialists as part of our treatment teams. Peer support specialists are people who have a lived experience with PTSD, but they're just further along in their recovery. Our patients really relate to our peer support specialists. Their lives are like this beacon of hope. And our peer support specialists have this very unique way of engaging folks in treatment, a really special, passionate calling to the work. And what about resilience? What is the role of resilience in preventing PTSD? As a society, we love to talk about resilient individuals, and we love to hold them up as an example for all of us to learn from. But we need to go further. We need to make whole communities resilient. We have to level the playing field so more people are given the opportunity to be able to thrive after experiencing trauma. Why don't we start empowering individuals with the knowledge, skills, and training that can make them more resilient before they experience the trauma? There are some programs out there. Stress inoculation training is one. It is a really well-tested, very effective program. Literally, people who are being trained in stress inoculation training are exposed to stress, lower than a major trauma, but still stressful situations. They're exposed to them either via simulations or via using virtual reality technology. And the idea is, by being exposed to these lower levels of stress, they learn to recognize how their body might respond, and they learn relaxation strategies and ways to manage their body's reaction to stress, so that if one day they're met with a major trauma, they're better prepared to respond. It's not unlike having a vaccination. You know, when you go to your doctor's office and get your influenza vaccination, what are you getting? You're getting an attenuated or dead form of the virus, so that your body can get used to that virus, so that one day when you're exposed to flu, you either don't get sick at all, because your body's already used to recognizing that virus, or you don't get as sick as you would do if you hadn't got the vaccination. Stress inoculation training is routinely offered to people whose work exposes them to trauma, you know, where trauma is an occupational hazard, so like for first responders. Why not offer it to all high-risk communities? Surely that will help build resilience before trauma strikes. Surely that will help us prevent PTSD. And this brings me to the final point that I want to make to all of you today. Each one of us has a role to play in preventing PTSD. If you elevate your awareness about PTSD, if you get educated about what it is and what it isn't, if you keep an eye out for the signs and symptoms of someone who's been traumatized, you will be more trauma conscious. And then if you go one step further and educate everyone around you about PTSD, you'll contribute to us becoming more trauma-conscious society. And the more trauma-conscious we are as a society, the more spontaneous pathways for healing open up for trauma survivors. And the more spontaneous healing that goes on in our society means less PTSD in our society. And that is a truly wonderful thing for all of us. Thank you so much for listening, and I really welcome your questions.